Hello and welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And Wes, here we are. We're leading up to the most exciting meeting, I think, of the year. And we've got some really great content to bring to you today. But before we get into that, I want to talk a little bit about one of our sponsors. As we mentioned before, the OG sponsor, our first sponsor and the longest running sponsor with the Dental Guys. We're very grateful to the Dental Crafters Network. Discover the difference a relationship with the Dental Crafters Network can make. As a full-service laboratory, they pride themselves on listening and understanding your unique needs, guiding you toward innovative solutions that make a difference. Dental Crafters Network focuses on improving your patient's quality of life with cutting-edge digital dentistry solutions. Visit dentalcrafters.net or call 1-800-472-8302 and mention the Dental Guys to receive 10% off your next case. So if you just give our name, this is where name dropping is good. Drop our name. We want you to drop our name because that will be good for us and good for you. We know that our sponsors want to know, are our listeners hearing what we're saying about them? And so if you just mention us, you're going to get a great deal. And I promise you, you're going to get a great lab with great support. It's made a huge difference in my practice and my life to work with a partner like the Dental Crafters Network. So thanks again to them for bringing this episode to you. So Wes,
AO 2024, John,
talking about,
dude, it is coming. It is right up on us. We're just a few weeks away, and I'm super excited. Hey, listen, reminding you to text your comments, questions, 865-544-8954, and at the end of the show, we're going to have, we'll try to have a little bit of texting conversation, right? You might get mentioned on the show. Now, listen, we don't have time to talk about my haircut and John's haircut and what we're wearing. We want you to mention. The only way you're going to get on, right? The only way you're going to get on is if you mention your name, right? I'm not going to mention last names, and you can keep it simple, right? Keep it simple. I don't even care if it's like a stage name, right? So mention your name and where you're from, where you're practicing at. And listen, we'll get you onto the show if we can, if it's something that we want to talk a little bit about or just to mention.
Yeah, and even if it's something that's coming up, if you've had a guest on, or we're about to interview some people like we are at the AO meeting, which, by the way, if you haven't registered, this is probably your last chance when this releases.
Yeah.
You've been living under a rock and you don't know what the AO is, go to osseo.org and register for the Academy of Osseointegration 2024 meeting, March 7th through the 9th in Charlotte, North Carolina. I hope to see you there. And because if you listen to our last episode, this is coming. We went back into the archives and we tried to find the very best of our last AO meeting interview series. And there is so much to choose from, so much good content, I think, that we're able to mine into. But we've got a real doozy for you today.
Oh, man.
This is, again, two clinicians and researchers that we have been following for years. One of the first people I remember vividly from my first couple of AO meetings was Michael Norton at that time doing Good Morning with Astratech. He was the MC of the morning show back then. And now, continuing as in leadership positions and always pushing the envelope. And at the same time, Tiziano Testori, who literally has written books
Dental
about
giant.
what we should be doing with sinus grafting, what we should be doing with insertional torque value. And Wes, that's one of the big topics that we're going to be discussing, or you're going to hear us discuss on this recap. So talk a little bit about what our listeners should kind of expect to hear, or a little bit of a preview of what we're going to talk about.
Man, this is a good one because, insertional torque value and ISQ, we've heard it for years about insertional torque value, and it seems like manufacturers have engineered implants surrounding the idea of greater torque because if it just feels tighter, it's probably right. Is that the right methodology? I think Dr. Norton and I talk about it, and he actually calls me out because I'm like, my dad's an engineer. You know, you'll hear him in the show. You know, he talks about we're not dealing with wood here, right? Well, what are we dealing with? Dr. Norton talks a little bit about that. And, you know, you're coming from two different perspectives here, right? When do we use tools to evaluate healing and evaluate how well does surgery go? We've talked about ISQ and how it removes doubt in the past.
Yep.
These are two people that are well published in the area of insertional torque value and also some of the newest literature regarding insertional torque value. Dr. Testori talks a little bit about how we're tracking that during the actual placement of the implant in this talk. And then Dr. Norton also talks about why we can't just use insertional torque value, why ISQ might be a better way. And in fact, at the end of this little talk here, this little debate between the two, and it is a debate, and I think we need more of this, John. John and I are going to come back on, and we're going to talk about, over the last 2 years, how hard are John and Wes leaning on either one of these methods for evaluating moving forward with surgery. It's been a couple years since we've talked about this, and so I'm excited about that. Hey, listen, this is going to be a good one, so stay tuned and listen.
Well, it's time to bring on our next guest.
Yes.
And I'm super excited to have Dr. Norton and Dr. Testori to talk a lot about really what has been on our minds since I talked to, and I'll tell my little story about insertional torque value. And I was placed in an implant that Dr. Norton knows so well back over 10 years ago. And I was at Lyndon Cooper, a very special event that company put on at UNC. And I went up to him afterwards and I said, so I've read a lot of your studies on bone and how it works. And I said, I trust the implant and I trust the technology behind it. But what I can't get past my mechanical mind, my dad's an engineer, is the fact that you say that a low insertional torque value here, as long as you can't, he said this, he's like, Wes, he said, as long as you can't spin it in the bone, in your hand, then trust it. And I was like, and you're second staging? So here we are 10 years ago where I'm burying everything. Like, I mean, let's put it all to sleep, right? And I go to, if it doesn't spin, put a healing abutment on it, John.
Right.
And I remember you telling you this, and you said you're a cowboy.
Right.
I said, but doc, what?
I did call you
the
a cowboy.
research. You called me a cowboy.
I did.
Right?
I did. And because it challenged my thought process. So here we have, Dr. Norton, Dr. Testori, both widely published in the areas of both insertional torque value. We've obviously talked a lot about that through textbooks, through articles, and also ISQ and resonance frequency analysis. These are both areas that you guys are both quite familiar with. And we would just love to have the discussion of, how much do these things matter? How much does torque matter? And how much should we rely upon it? How much does ISQ matter? And how much should we rely upon it? How tight is too tight? How loose is too loose? These are topics that both of you are, of course, very well versed in. We'll start with you, Dr. Norton. Talk a little bit about today, your thoughts on these issues.
So thank you for inviting me here. It's great to join you guys. And let me start by saying I was being very kind to you because I told you, according to you at least, that we stop at spinners. We absolutely don't stop at spinners. Spinners are our friends. We put a healing abutment on them.
This is what I was waiting for.
It's absolutely no issue.
Yes.
And in fact, the way you introduce that topic, it's like reeling in the bait. I mean, you said your dad was an engineer. Is that what you said?
That's right.
Yeah, well, I got news for you. We're not carpenters and we're not engineers. We're biologists.
Yes.
We are surgeons treating a living vital tissue. We're not working on bone, on wood, I should say. And there is a fundamental difference. I mean, let's keep the metaphor going. Okay, so you have a picture or a painting. Human beings are actually really good. You pick up in terms of visualizing the concept of primary stability. How do I mean? So you pick up a painting or a picture that you want to hang on your wall. you immediately get an impression in your mind of how heavy that painting is. And that impression in of itself gives you an understanding of how big the screw or the nail or whatever you're hanging it up with, right? How big it should be, how deep it should be. And when you drill into the wall, right, is it brick? Is it breeze block? Is it drywall? Your brain immediately calculates the bone density of that wall, if you'll run with it.
Oh, yeah.
Right?
Yeah.
And somehow or other, you make a qualitative assessment of how big the screw should be, how deep the screw should go into that wall in order to hang that picture. Because, sure, you don't want to come down the next morning and find the picture on the floor shattered into pieces, right? The problem is that substrate is an inanimate substrate. It has no potential to change the way in which it interfaces with the screw. So you go back 10 years later, you hate the picture, right? You hate the frigging picture. You want to take it off, but now you've got a screw in the wall. So you want to take the screw out and patch it up or whatever you want to do. Thing is, you can take the screw out. There's been no change in the relationship between the screw and the wall, the screw and the substrate. That is not a dental implant, and bone is not an inanimate substrate. So now if we bring it into the biological realm, you take that same innate understanding, and it's an amazing innate understanding, but you apply that to a living vital tissue like bone. And what you actually do is you damage that bone, okay? The desire for getting this massive insertion torque so that it's really tight, so that you can go home and feel good about the fact that your immediate load provisional or whatever isn't going to fall out that night. That's fine at that level. But what you don't see is what's happening at the cellular level. The damage you've done to that bone through super compression, right? The potential start of a pressure necrosis curve, which may not translate all the way through to actual pressure necrosis, but the literature is abundant with evidence that you damage that bone. Now, I'm not saying, and I have never said, that translates to higher failure of implants, because it probably doesn't. But what it absolutely does is translate to a poorer quality of osseointegration that takes longer to achieve because of the damage you've applied to the bone. Well, I don't want that. I want quicker osseointegration, and I want a better quality of osseointegration. And the way you do that is to respect the bone, to get enough primary stability, however we measure that, which we're going to talk about this evening, to get enough primary stability to do the job, but without insulting the bone. And that's always been my position. And it's still my position.
Yeah, Dr. Testori, respond to that. How do you feel about that and the pressure necrosis curve? And this, is it just a matter of putting it in to feel good about yourself at the end of that procedure?
No, I think he made the point that the last word, you should not do any damage to the bone first. But pressure necrosis, and we wrote a white paper with Alan Meltzer many years ago, myth or reality. We think that it's a myth. So to be very practical, first of all, should I do an immediate load case or should I do a delayed case? If I should do an immediate case, single tooth restoration, I got to have that implant that is stable. And the implant should not scream in the bone, but the implant should have 40 to 50 Newton centimeters of primary stability. And we rely upon insertion torque, incremental insertion torque. So the curves should be incremental. We don't like to have a flat curve and all of a sudden a peak torque. To be very practical, we never teach to under-prepare the cortical, because if you under-prepare the cortical, the implant cannot go flush with the bone. So it's a matter. And on top of that, it's a post-extraction case, is not a post-extraction case. And then we learn over the year how to respect the bone, not doing any damage mainly to the cortical, but the implant should be stable in medullary bone. That's our position. And on top of that, we speak about torque, but which device you have, which drilling machine, because clinicians take a lot of attention on the implant, the hardware, but not on the drilling machine. You got to have a reliable drilling machine that gives you the readings, because otherwise, and then another big issue opens. Is the handpiece well lubricated? It's old, it's not old, which kind of burrs are you using? Are you doing guided? So there are multiple factors that can mislead the clinician in the torque value readings. And on top of that, you should always give a limit to the doctors in order to understand that which is the average torque that you need to have. For single tooth application, in the range of 40 to 50, even if there are papers in the literature, if you take the Kayat kind paper, is showing you with the Nobel implants, with the real torque device that can measure the torque, implants that goes in 172 newtons. But then you should ask yourself, ask the company, the implant system that you use, at which torque you have a deformation of internal X or the external X, because otherwise that implant will not be used for a single tooth application. And then you should really understand the biology behind that. In the next issue of Geomy, we published 39 very atrophic mandibles. That means 6-7 millimeters. White bone like this desk, so very dense, 20 newtons, and immediate loading, because in very dense bone, you cannot have micro movement, and we did immediate loading. And the referees gave us hard times, and they said, how comes that you have clinical success, but you have only 20 newtons and you immediately load? It's too low. No, you don't know biology, my dear referee, because the bone is white like this. We are in the interforaminal mandible. So you have to control the micro movement, and the insertion torque and the primary stability in very dense bone is not that important. In dense bone can be detrimental, not to the bone, but fracturing the mandible. And we present in one case in which at the university, the guy was placing the implant, not following the protocol, and screwing the implant because of immediate loading, not following my guidelines, and we have an initial fracture of the mandible by torquing the implant. So primary stability and bone quality, they got to be in some way very well known by clinicians. And on top of that, the shape, the macro geometry of the implant. Every kind of implant has a kind of specific indication. It depends on we do a lot of post-extraction cases, and that in order to have in the upper jaw a better primary stability, the macro geometry plays a role. Because if you don't have enough bone at the apex of the tooth, can I still do immediate loading? Yes, you can, but you got to have the right shape. So I perfectly agree that biology is very important, but on top of that, we should take into consideration which kind of drilling machine, the armamentarium that we are using. We get to know that. And on top of that, all the other factors.
You know, the market has definitely followed what Dr. Testori is saying, is that, you know, we're going to change the design of our implant to make us maybe feel better or follow along the lines of these V threads in that medullary bone these compressive threads in that upper middle third, and then less pressure on the cortex because, well, we know what happens there. And then also I think about resonance frequency analysis and the fact that research has really shown that it is the only way to truly track bone to implant contact, which in a smooth or maybe an older school design implant where we had lower insertional torque values, we had maybe more BIC, right? And we achieved similar outcomes and maybe better outcomes than high insertional torque values.
Speak to that, Dr. Norton, because I know you've published several articles. I remember going back years ago to an editorial in Jomi where you talked about viable constraint. And that got us thinking as you actually had an equation. It was a beautiful thing to see an equation. We like equations here at the Academy.
We can quantify something.
Yes, but that got us thinking a lot about how much we should push this idea of torque. But as a counterpoint to that, or maybe to add to that, where does the ISQ fall in a way of comparing these two approaches? Because it seems that may be a way to differentiate.
Yeah. So, I mean, first of all, let me say I have a huge respect for my opposition camp. Okay.
We knew that.
And I think it's important for your listeners to understand that this is educated debate. This isn't
this is true science,
this
though,
is
right?
true science, and it's not a duel.
That's right.
Okay. It's a search for the truth. The first thing I want to say is it's very interesting to me. I am a clinician first and foremost. I'm not a bone biologist. I'd like to think a part of being a clinician is being a biologist, but I'm a clinician first and foremost. And yet the interesting thing is actually, if you distill the literature in terms of all of the articles written about particularly the influence of high insertion torque on what you affectionately call BIC, which for those who don't know stands for bone implant contact. And those who are proponents of high torque, like Alan Meltzer particularly, what you see is that it's actually the bone biologists, the pure bone biologists, the guys who are in the fundamentals like John Brunsky and Jill Helms and Lyndon Cooper. These are the sort of people who are looking at the way a bone cell reacts, at the way things happen at the biological level. Whereas the people who are publishing, like Philippe Kayat, who I know extremely well, and Alan Meltzer, and others who are proponents of high insertion torque, are pure clinicians, right? And I think that goes to tell you something.
Yes.
Okay. What I've tried to do from my editorial, which you so kindly brought up, 2013, and I was very grateful to Steve Eckert for allowing me to publish that, because that really was the firing gun for this debate. What I was trying to do was to try and see if we could start to achieve a middle ground between these two camps. And I think bone to implant contact, and I refer to that as just quality of osseointegration. There is a huge difference between talking about quality of osseointegration and implant success. An implant can be very successful in terms of, does it drop out or does it stay in? And the quality of the bone implant contact. Actually, an Italian colleague of yours, Paolo Trisi, published a fascinating study, one of the first studies in the sheep model, you may remember, looking at high versus low insertion torque. And what was interesting in that study, and he saw his own results in a very different way to the way I saw them, but in his high insertion torque studies, he got a lot of microfractures of the bone. And in the low insertion torque study, he actually had a gap between the bone and the implant surface. And so the way he presented that was basically to say that in the high insertion torque group, they had a high bone to implant contact. And in the low insertion torque group, they had virtually zero bone to implant contact, but only because they'd over prepared the osteotomy. But when you looked at the 6 week or 4 or 6 week follow up, I don't remember what it was, there was a mass resorptive process around the high insertion torque implants. And there was actually a de novo bone deposition filling in the gap in the low insertion torque group. So this is the way that biology responds to pressure. Now, Tiziano, you said yourself, you know, in that marble bone, that quality one bone, you only had 20 Newton centimeters.
Yeah.
And it was interesting to hear what you said about the editor's reaction. One of the articles that and I'm going to embarrass myself now because I'm getting senior in age and I'm starting to forget things. It's an article that I've referenced a million times. And for the life of me right now, I can't remember the name of the author. But in this 2006, I think it was, article, the authors were doing atrophic edentulous mandible immediate load cases. And the most amazing statement in the discussion section of that article, and I'll have to send you the reference because it's not coming to me, but if it does, I'll tell you. They actually identify or point out that they had a minimum target insertion torque of, I forget what that was as well, 40 Newton centimeters, let's say. And something like 75% of all the implants failed to achieve the requisite insertion torque. Most of them, something like 60% of them, were under 25 Newton centimeters, but they got a 98% success rate. And in the discussion section, they themselves questioned how was it possible that they got that degree of success with such an inadequate insertion torque. How is it possible that Tiziano has done what he's done in this marble bone at 20 Newton centimeters? So that brings us very nicely into the discussion on ISQ. Because if you take the marble bone, that quality one dense bone scenario, let us imagine, if you will, that you prepare the osteotomy to full diameter. You then use a bone tap, let us say,
Sure.
right?
And cylinder implants.
And cylindrical implants. So now you have an implant that has pretty much no compressive friction, rotational friction or compressive friction against the osteotomy, because the osteotomy is now basically not only the same diameter, but it's been pre-threaded.
It's machined.
It's machined.
Yes.
Right.
Yeah.
So the question I have for you is, how can that have any primary stability? Well, the answer is because the biggest misnomer in implant dentistry is that primary stability is measured by rotational friction. That makes no sense.
Right.
Primary stability is measured by axial stiffness.
Here we go.
And if you have a perfect fit between an implant and an osteotomy in dense bone, where there is basically no compressive friction at all, you still have a very high axial stiffness. So now you have the perfect combination of high axial stiffness, zero compression on the bone, so you haven't destroyed the bone cells. They're happy days. They're going to produce new bone, and they're going to osseointegrate faster with a higher BIC, as you call it, in a shorter time. And that's what we look to achieve.
So
I think
so in saying that, where do we see the problem with that line of reasoning? Is it, you mentioned that you feel that the pressure necrosis is a myth, or that you feel that it is not as important?
It's a myth within the boundaries. We get to give numbers to the clinician, because high insertion torque, we should give them guidelines, and they should stay within the boundaries of those. I mean, high insertion torque, if you speak about 70, 80, it doesn't mean anything, because you don't need that. It can be detrimental to the geometry, inner geometry of the implant, can be detrimental to the bone. So the guidelines for the guys that are in the field working on patient every day, do not under prepare the cortical layer. You got to have congruency with the cortical layer. You got to pick up the right implant shape according to the bone. In our data set of mandibles, 39 mandibles, is not a big data set, but we have almost 200 implants. Very old patient, cylindrical implants, and the thread pitch 0.6, pre-tapping, no important primary stability to 20 newtons. And one point that I already said, it's very important for us to understand that we got to have a reliable tool. At the beginning, to be very frank, I was involved with the hostel, with the resonance frequency analysis. Then over the years, we forgot to use that. It faded away because I am surgeon and I'm placing the implants, and I do not see the need now for resonance frequency because I have 41 years of practice. My first implant was placed in 86. But I think for the less experienced doctors, I think resonance frequencies analysis is very important to understand. And then for secondary stability, I do think it's the only way we have to monitor the implant. So from my perspective is very important resonance analysis frequency. If you have referrals, to check for litigation, and even to prove that you have osseointegration, to monitor the implants down the road. And maybe for guys that they have a lot of practice, a lot of experience, might not be so relevant at implant placement. This is my idea, but it's something that no doubt there's a scientific base behind that, a lot of literature, and every young doctor should study that and get involved with resonance frequency.
Well,
so
yeah, you've got it.
I got to come back.
I saw
on
you
that.
shaking your head there. We've got just a few minutes here. Okay.
So first of all, the first thing to say is people don't have to believe in pressure necrosis or not believe it. Go onto Google, type in dental implant pressure necrosis, look at the stack of images that come up. They're all aggressive thread implants. All of the pressure necrosis is not in the cortex, it's in the cancellous compartment. This is real. I see it regularly from patients that are referred to the practice. What really gets me angry is that the accusation is that these implants have failed from peri-implantitis. This is not peri-implantitis. This is unacceptable carpentry masquerading as surgery. Set that aside for a second. Let's just talk about ISQ. I have 32 years of experience placing implants. Like Tiziana, I've placed thousands of implants. I think I understand and know what represents good implant placement. I have lots of patients that I still see who I treated 20, 25, coming up 30 years ago. So I understand it. So why the hell would I bother with ISQ?
Right.
I'll tell you why. And this is the mistake, I think. And I met with the guys today from Ostel, and you could level it at the whole, if you like, marketing of that concept. ISQ should not be sold as anything more than a 2-measure instrument. Torque is a 1-measure instrument. You can't go back and remeasure the torque and get any appreciation for any change in the interaction between the bone and the implant. I don't care how experienced I am. I get, my personal success rate in practice is audited every single year in, year out, has been for the last 30 years. My success rate is somewhere in the region of 98 to 99%. Okay, so I have every single year 1 to 2% failure rate. So you could say, well, why bother with ISQ for that? Answer, because I want to eradicate the 1 to 2%, because I don't want any patient to be that 1 to 2%, because for that patient, it's 100%. Well, I restore a lot of the implants I place. And one of the beautiful things about ISQ, whether you believe it predicts failure or not, it's irrelevant. It's a red herring. What predicts, and it's not a prediction, it's an actual, is when you see an implant placement, you had a primary stability as measured by ISQ of, say, 78. 3 months later, you come to take the healing abutment off and take the impression for definitive restoration, and suddenly the ISQ is 65.
Oh my.
You got to ask yourself a question,
Right.
right? You got to take an X-ray. You maybe take a scan, because maybe you don't even see it on a two-dimensional X-ray. But you have to ask yourself questions, and you have to delay the restoration of that implant. That's why I do ISQ, because nothing else in the industry gives us the opportunity of comparative assessment of the bone implant interface, and nothing else is currently available that gives us the opportunity to at least try to eradicate that 1 to 2% failure. Talk can't do that for you.
Right. Now, I will say, just to kind of come back to the, oh yeah, go ahead. Of
One
course.
thing, I am a medical doctor, and it's important not to rely only on one factor in medicine. You have to rely on multiple factors. And we learn over the years how to fool the instrument. If you have an implant, you have a cortical layer, no bone there, very little density of that bone, and you hammer the implant and you take an ISQ, you can have very high readings, but that implant is locked only in this cortical layer.
Yeah, but that's only one reading, Tiziano. You have to retake that reading some months later, and then you're comparing like with like.
Yes, I'm telling you, at first stage surgery. I'm not saying that it's useless, but I'm saying that you got to have multiple factors
100% agree.
to analyze, and then you get to know biology, and you got to understand how the tool works, because
100%.
otherwise, if the young guys only at least one readings, and on top of that, if you are in the, let's say, poor quality bone, and you got to screw the post on top of you can lose a little bit of primary stability. I've seen that they can move. So there are multiple factors to analyze.
Yeah. There's no question. If you only use ISQ as a one reading instrument, it's no more valuable than using torque as a one instrument reading.
Well,
it's useless.
And how important, conversely, then I will say, you mentioned, spinners are our friends, right? So if you're going for an immediate loading situation, right? What are you shooting for? Is insertional, is ITV something that you say, well, I would like to have a certain number? Does it matter more when we're immediately loading than if we are planning on doing a two-stage situation?
So in my 2017 article, where I use ISQ to look at, could we identify a threshold of insertion torque where axial stiffness actually becomes more predictable? I've always in my lectures said 25 Newton centimeters, 20 to 25 Newton centimeters is the minimum threshold. I probably still stick by that, but actually I disproved that, because in my 2017 article, what I actually showed is that the variability of ISQ values was very wide for all implants placed under 10 Newton centimeters. But when you got above 10 Newton centimeters, the variability in ISQ was almost nothing. I mean, the distribution around the mean was minuscule. And so actually what I demonstrated in that study is that anything over 10 Newton centimeters actually has a predictable stiffness. So if you have an insertion torque above 10 Newton centimeters, which let's face it, most people do, okay, whatever your ISQ value is, it's probably pretty accurate. You could take it 100 times, it would be that value. So if that value is under 65, you have an unstable implant. You should not immediately load it. But if you have a value of 68, 70, 75, and let's be clear, you can have an ISQ value of 75 with an implant that has an insertion torque of 10 Newton centimeters. I have no compunction loading that implant immediately.
Well, there you have it. We're going to be 40 to 50, right?
Yeah.
And we're going to have an insertion torque of 10, but we're going to have to read an ISQ of at least 65 plus, right? And so I hate to even shut this down
I know.
because here's the thing is that for years I've read these articles.
Oh yeah.
I'm teaching this. My first slide in the recent lecture that I taught, you saw it.
Yeah.
It has a mechanic on one side, split right down the PowerPoint slide, and has a biologist on the other side. And it has this little circle spinning with arrows, right? And it's teaching dentists to not just be a mechanic, to be my dad's engineer, but to be a biologist, to be a doctor, like you said. And one of the things about doctors is we do like to have two things that confirm a diagnosis, right? And I know that with recent things and even my own family, and learning about diagnosis and diseases and how we do things. And I think as we become better doctors, we'll become better mechanics. And for biology that's dynamic and not static. I really want to thank Dr. Norton, Dr. Testori for coming on.
Well, that was what I hoped for. There were some fireworks, there were some disagreements, there were some tense moments, but there were also two very strong opinions that I think were expressed very well by both sides. I think the questions you heard us ask, we wanted to have answered were, is higher torque better, or is it dangerous, or maybe even destructive? And can we really rely on ISQ? Is it really validated? And I think to hear these two to talk completely differently about their feelings was beautiful, Wes. I mean, I love that because I think we all want to know, for whether we're doing surgery or restorative on dental implants, we want to understand what is the best approach. And if we have a failure, why did we have the failure? And I think those were some of the things that started to get us thinking. So Wes, talk about your takeaways from this, and how is it changing, or how has it been changing the way you think about dental implants in your practice?
You know, at some point in this, if you're watching this, you could see the disagreement on both excellent clinicians and speakers' face. And I think Dr. Norton, you know, extended the olive branch in a way there during the talk about how that, you know, they don't have anything against each other personally. I love that, you know, and this is a debate of academics and science, and this is actually where we actually start to make clinical decisions. Both of these two people are practicing clinically, and John and I are practicing clinically. John and I both place dental implants and have for a long time. And so some takeaways for me, it reinforced what I was doing and what I am doing now in 2024. And so if you ask, am I using insertional torque value to evaluate whether we move forward with certain aspects of prosthetics during surgery? Absolutely. And but I primarily rely on primarily rely on ISQ, implant stability quotient. You might be saying, well, what is all this, right? Because we really didn't go into that in the lead up or in the show. So just for quick here, right? Back in the 90s, integrated Ostel group, actually in, I think it was in Sweden, John, were working on a way to evaluate implant stability by sending a harmonic vibration. Just think of a tuning fork and what's going on there down through an implant. And what this instrument does is it's a quantifiable way that gives you an actual number based on research. And that number actually correlates to the implant readiness, right? And so they have a scale that tells you, okay, if you get this number, then it should be okay to do this. If you get this number, you should be okay to do this, load, put a crown on it, splint it, you know. So we have a value now that we can actually track healing. And the key is that insertional torque value is a mechanical value. Insertional torque value is torque, right? And torque measured in a circle, right? So force measured in a circle, I should say it that way, is what torque is. And so it's mechanical. It's like going into wood, right? And as Testori said, he had certain ways to track torque, right? He said, you know, we need to watch this line. And he said it's not good for an implant to be going in at low insertional torque and all the way in until it gets to the very end, and then you get this spike in torque. And even Michael Norton said, hey, that's bad because that's putting all the pressure on the cortex, which could promote dieback because that's the least area of blood supply during healing is right there at the cortex. And so what we want to be able to do is to assess, you know, torque, what Testori is saying, over, it needs to be linear, right? As
Right, and that most of our torque, I think you get from both of these gentlemen, that our torque should be coming from the vascular part of the bone, the medullary bone,
medullary
as opposed
bone.
to cortical bone. And I think that everyone in this camp that has been reading literature agrees with that. The question of how much is too much, you know, Norton tried to determine that with his viable constraint calculations and things to figure out what that looked like. But in the end, we kind of have to look at this from a standpoint of just what does the science tell us would be the highest chance of success. And that's to not overload, if you will, that cortical 1 millimeter. So interestingly, we've seen some new designs. We've seen some new designs that are now really taking that to its fullest. And if you listen to this episode today, as well as the last one that we talked about with Dennis Tarnow, you know, their group has used not only the ideas that we talked about last with the grafting and how to manage sockets, but also the idea of where our torque should be coming from to completely develop new designs of implants that cannot get their torque from the cortical bone by having a much different shape. And we can talk more about that in coming episodes. But just suffice to say, this is something that's changing the way we think about insertional torque, ISQ, and even implant design. Companies are finally figuring out that if they want to have the highest success rate, not just success, but the highest aesthetic values in their research articles, the PES-West score, those types of things, that they have to have designs that are respecting the cortical bone, getting the torque from the right place. So look
Did you
forward
just say
to it.
PES-West?
Oh, I did. I brought it.
I mean, use some acronyms there, John.
Pink aesthetic score, white aesthetic score. This is what this is where we get to the super nerd comes out sometimes, you know?
Yeah, super pumped about what we just heard there, John, because really it did confirm for me that I need to continue using both of these ways to evaluate implant stability during surgery, and then afterwards I'm relying 100% on using implant stability quotient. Someone once say, well, we're using an instrument to perform resonance frequency analysis, and we get an implant stability quotient, the number. John, are you using this in your practice today?
Yeah, we use it for every implant, not only implants that I place, but also to be able to help if an implant comes into my practice that we have questions about that I didn't place, that we can track some things about how they're healing, whether they're ready for loading, or if there's a problem.
So let's talk about some controversy. Let's talk about some controversy here real quick, okay? And listen, text your comments right now about this right here. How many surgeons, periodontists, and oral surgeons right now, general dentists, are you listening? Are you using only one of these, right? Are you just using the
I know the answer.
Insertional torque? Are you using implant stability quotient? right?
How
Because
about I'll rephrase that and say, if you have a surgeon that you're working with, or you are a surgeon that's using ISQ routinely, I'd like to hear from you.
I would too, because I'm not seeing
these
it.
No, it's unicorns. And
and I'm disappointed.
And it's a big problem. I'm not saying it's a surgeon problem. A lot of it is that if you're a restorative dentist and you're restoring implants routinely and you don't even know what ISQ is, I'm not saying you're bad. I'm saying you don't know how to have that conversation anyway. And most surgeons, I think, understand that in order to educate their restorative referrals, it's a lot of work too. So I think it's on both sides. There's been a lack of knowledge on this topic, and I think that it would serve our surgeons to help educate the restorative dentists about this, and it would behoove our restorative dentists, if they know that this could be valuable to know if an implant's ready to be restored, to potentially educate their surgeon on this topic, because I think both sides need to be better. So yeah, text your questions to let us know what you're seeing. If you have people that are using either one of these primarily, we'd love to hear what your feelings are. And that number, so Wes has put that up on the YouTube, but just so you have that, it's 865-544-8954. So if you're in the car, on the mower, 865-544-8954. You can text your questions and comments to the Dental Guys. Before we conclude, we'd like to once again thank our sponsor, the Dental Crafters Network. This episode was brought to you by the Dental Crafters Network. Definitely go check them out at dentalcrafters.net. Wes, it's been a good one. This is one of the better conversations we had at that meeting. I'm looking forward to a lot more.
Yeah. Can't wait to see you at the Academy of Osseointegration. John, I'm super excited to see you there right across from me as we interview some of the greatest minds in the field of dentistry. Get ready. It's going to be amazing, right? The Dental Guys at the Academy meeting this year, 2024. Pumped about that. Hey, like, subscribe, share. The best way to get the word out about the Dental Guys is to tell somebody, and we appreciate all that you do for that. Check us out on YouTube or your podcast catcher app, and don't forget, we are the Dental Guys.